Hello everyone, I am Dr. Tamer Seçkin and I am an endometriosis surgeon. My passion is to treat the disease endometriosis. As you may all know, endometriosis is a disease that affects females of reproductive age in their most productive years, however causing them severe loss of quality of life, subfertility, infertility, major cause of hysterectomy, and #1 cause of pain in women. Today, I will introduce you a series of very interesting individuals, professionals, and some patients who are willing to come out and share their experience with you. But let me introduce these friends of mine, my circle, who we have worked together for many years, who have also taught me, and we have shared a lot of knowledge, and that's how we work with endometriosis patients. It's a team practice. My colleague, Dr. Ken Sinervo from Atlanta, will talk about endometriosis of the bowel, why IBS is not necessarily the disease of unknown, but disease endometriosis of bowel.
I think the most important thing initially is making the diagnosis of endometriosis. Unfortunately, a lot of women who present with symptoms of bowel disease are often shuffled off to their gastroenterologist from the gynecologist's office instead of focusing on the possibility of, well, could this be endometriosis involving the bowel or endometriosis in general? Endometriosis is very common, occurs about 10% of the time. Endometriosis and bowel symptoms are very common, with probably 90% of patients with endo having at least one symptom involving their bowel. Bloating and nausea are very common. The more common things to suggest bowel disease are constipation, diarrhea. Sometimes it can be alternating constipation and diarrhea. They can also have painful bowel movements, which are very indicative or suggestive of invasive disease involving the bowel or adhesive disease involving the bowel to the back of the uterus, as well as intestinal cramping. Those are really the four most important symptoms to suggest endometriosis involving the bowel, and often something that won't necessarily be diagnosed at the gastroenterologist's office. Specifically in terms of endometriosis involving their bowel, after I've gone through the regular list of questions to know or suspect endometriosis involving the bowel, then I would specifically hint on, okay, do you have any intestinal cramping? Do you have pain with bowel movements? Do you have alternating constipation or diarrhea? Do you have a lot of bloating, which would suggest small bowel disease? Do you have pain in certain areas, either in the right lower quadrant to suggest endometriosis involving the small bowel, or pain deep down in the pelvis? Even painful intercourse could be suggestive of disease between the rectum and the vagina, which could be invasive in nature as well. A lot of endometriosis patients ultimately do get diagnosed with something called irritable bowel syndrome, which is kind of like a wastebasket diagnosis for, a gastroenterologist. They acknowledge that you have these bowel symptoms, but they don't see anything anatomically or pathologically wrong with your bowel, so you're given the diagnosis of irritable bowel syndrome. Okay, what a gastroenterologist's role in helping to get to the bottom of the bowel symptoms is first to rule out other causes of bowel disease, such as lactose intolerance or celiac disease, which is also called gluten intolerance, which is a sensitivity to wheat, rye, barley, and possibly oats. As well, we want to rule out inflammatory bowel disease, which is ulcerative colitis and Crohn's disease. And then finally, ruling out cancer in patients who may have other symptoms like weight loss or blood in their stools. Once they have done that, and part of their workup is first to do some blood work, they're also going to do some stool cultures to make sure there isn't an infectious cause for their bowel symptoms. They also may consider doing an upper GI or an endoscopy to look inside the stomach to rule out those other diseases. And then finally, they're going to do a colonoscopy, okay? If they do the colonoscopy, they may pick up disease involving the bowel that's invading into the bowel, probably less than 5 or 10% of the time. So even a colonoscopy, which is the best thing that a gastroenterologist has, may not be the best thing in terms of diagnosing invasive disease of the bowel. So really what you have to do is you have to focus on the severity of the symptoms, if they have a negative workup, or if the gastroenterologist does see a lesion on the bowel, then it's something that needs to be addressed through surgery, but it may not lead us to the diagnosis of endometriosis involving the bowel. IBS is a diagnosis of exclusion, and once all those other pathologies have been ruled out as well, and you think that the patient has endo, then really the next step is a laparoscopy and treatment of the disease, which ultimately should be excision of the disease to completely get rid of all the endometriosis. In general, if you were to look at all patients who are seen in the general population, endometriosis involving the bowel is somewhere between 15 and 20%. We have a much different population group in which we see a lot of patients with more severe disease, and probably at least 1/3 or more of our patients have endometriosis involving the bowel, or adhesive disease in which the bowel is being compromised, which could also create those symptoms. The key to treating those patients is finding a comfortable surgeon who's okay with working on the bowel, mobilizing bowel, removing the disease off the bowel if it's there. Superficial forms of treatment are not going to be effective because, one, they hold the risk of injuring the bowel, and two, they're not going to completely get rid of the disease. Ultimately, the disease can be treated with excision by either excising the disease superficially, if that's as far as it's penetrated into the tissues, or doing a discoid resection with either cutting out the area and over sewing it, or possibly using a technique developed by Dr. Rich in which we use a stapling device and bring that abnormal tissue into the stapler and cutting it out, or if necessary, cutting out the whole portion of bowel, which typically runs around 3 or 4 inches, but it could be as much as 8 inches if there are skip lesions as well. But fortunately, there's a lot of redundant bowel for most patients, and they can tolerate that very well. When it's on the large bowel can undergo several feet of removal if necessary, although typically it's probably only around, again, 6 to 8 inches in a larger situation. When it's the small bowel, you can even take out several feet of that before they start having side effects. But ultimately, once all the endometriosis is completely excised, over 98 or 90% of those patients with invasive disease do well long term. And in general, patients who have superficial disease, probably 80% of them have significant improvement in their bowel symptoms. And while a small percentage may still have IBS, the great majority of them will no longer have IBS symptoms. Having the skills laparoscopically to mobilize the bowel and to feel comfortable working with the bowel to get it into its normal anatomy. And that often means, restoring anatomy in other locations like the ovaries, the tubes, the pelvic sidewalls. And once you have that skill set, it's being able to have the appropriate tools or techniques to excise the disease off the bowel, or if necessary to do a bowel resection. Most gynecologists wouldn't do that themselves. They would usually have a general surgeon, who would help them, or a colorectal surgeon who would help them cut out that portion of the bowel and restore the anatomy to normal in that regard. So really you have to have a good group of people and really a multidisciplinary approach to managing endometriosis. We have urologists, we have thoracic surgeons, we have general surgeons who all collaborate, as well as other auxiliary people like pelvic physiotherapists and nutritionists and psychologists to really deal with the whole gamut of situations that can be that you come across with dealing with endo patients. In terms of minimizing long-term problems, one, again, you have to have very good surgical skills and have the appropriate people to remove all the disease that's there, and recognizing deep disease when it's there.